So we're here today to take a look at treating the cervical column in a seated position. It's something that a lot of people are quite interested in because it seems somewhat abnormal or somewhat exotic, because most of the time when you're treating somebody's cervical column, they're laying in supine, so they're on their back. When they're on their back, it's actually one of the most controlled positions. So if we look at the concepts of patient positioning, the table makes stable, supine and prone are the most stable because there's the most proportion, or the largest proportion of the patient in contact with the table. So they're quite stable, and it's very easy to move the neck in relation to the rest of the body in a supine position. Now, I purposely wore a different shirt for this video because what I want to purposely attempt to make people to take notice of is if you're wearing a shirt with some essentially some kind of different texture or different level or firmness in the midline. Now in this case it's a zipper, but in other cases you may be wearing a dress shirt with buttons or a polo with buttons, because some people will wear those in clinical settings. So I purposely wore a shirt with a zipper just to make note of the fact that when you're treating a patient with respect to the cervical column in the seated position, you want to consider things that are on your midline. So in this case, I have a zipper, and if I was to have the patient place their forehead or their head against my chest, essentially as a fixed point or as a point of resistance. So if we look at the concept of relational motion, one thing stays still, one thing moves in relation to it. We can use our thorax as a stopping or an abutment for the head in order to control the cervical column, but I want to be careful of what's here. Now I understand that in some places, in some professions, it is not necessarily acceptable by regulation to have the patient directly in contact with your chest, and that's going to be completely dependent on those circumstances. But in the case of osteopathic manipulative therapeutics or osteopathic manual therapy, it's not an abnormal thing. If there's ever an issue that a practitioner doesn't want to do this, then they don't have to, there's no reason. If ever there's an issue where a practitioner wants to do this but is concerned about having a patient in contact with their thorax or with their sternum, what you can do is use a pillow or a towel to create essentially an artificial barrier. But in this case, it's not an issue for me, it's not an issue for the patient. So what we'll do is we'll just give you a general understanding of the holds and positions. So as I said, I'm concerned about things on my midline that can create challenges for the patient. Now, as far as assessment is concerned, we always use large motions to identify small problems. So in this case, what I do is I stand in front of the patient, I make sure that, you can't see this because of the frame of the shot, I make sure that their hands are off to the side and that there's some space between their knees because I'm going to stand in between their knees. So what you usually say if you need more space is take your knees apart, right? And you want to be careful about your words because there's other things you could say that would make people somewhat uncomfortable. But in this case, the knees are far enough apart. So what you'll see is I step in. So we talk about the concept of the space between us is unstable. So we want to minimize negative space. So what I do is I step forward, I bring the patient in towards me, all right? So you see that I have a fixed point. I have something to work with. I have resistance if I need it. I can contact the full neck, right? So broad contact for multi-point discrimination as a passive test with side bending. Now recognize that the patient's thorax is moving, and I completely understand that, but what I'm testing broadly is side bending in the cervical column. Now there's greater resistance in side bending to the patient's left, side bending to the patient's right seems easier to me under these circumstances. Now that's not the easiest thing to figure out. That can be challenging because it's hard to see. What's easy is you have your patient turn your head to the right, just twist your head as far as you can and lay that on me, and then turn your head to the left. And now what I can do is I can see the crown of their head. So as he turns his head to the left, I see this, turn your head to the right, and it moves quite a bit farther, so it's easy to see. Now if I wanted to go indirect for some reason, then here, now you see I've got lots of contact, lots of control. I'm not going to stand out here. I'm not going to have my elbows way out. I'm going to contact here. So I've got contact with the front of the patient's shoulder for stability. I can wrap around the patient's neck. And now here I can go indirect. So the concept of contact being control, it still applies here. I can hold, hold, hold. I can wait. I can monitor. I can look for softness. I can create compression. Right? That's something that I can do if I wanted to go indirect. If I want to go direct, turn your head to the left. Okay, you clear space. Now as the patient's here, the same concept applies. Now, if I want to consider relational motion, the challenge that the patient is having is essentially getting his chin over his left shoulder. So what I can do here is I can control the patient's head, and I can bring his shoulder towards his chin. So I have relational motion. I can stabilize the head. Patient's quite comfortable. If I want to use a patient active approach, turn your head to the right into my chest and let go. Right? And we get small gains. And again, the relational motion. I pull the shoulder towards the chin, and I let the chin travel towards the shoulder. Turn your head into me again. Nice and easy. And let go. Right? So we've got our opportunities to work there. Now, what I will say is in a seated position, if you're in front of the patient and you want to work on the cervical column, rotation is much easier to control. Side bending is not the easiest thing to control because they're on your midline, and you may have a hard time with the uniting palpation and vision. It's not the easiest thing to do. It's not impossible, but it's also a little bit harder to control the patient because essentially what you're doing is you're creating side bending, but the patient's wiggling under you quite a bit, so they're not as stable. It's not the most comfortable. So what we'll have you do is flip around and face the other way. So the same concepts apply when you're behind the patient. The one thing that I will say is when you're behind the patient, it just seems to be more advantageous to work with side bending in the coronal plane. So what I can do now is I can test. So you see I use lots of contact. Now I approximate to the patient, or I bring the patient to me, right? And I can side bend that way, and then as a comparative, now this I can see. I can side bend that way, but I've got good frames. Now, I can create rotation, right? But it's a little bit harder for me to control because I'm going to come across the patient's nose and their eyes. It's not the easiest thing to do. I can come in here, but as he pushes, I'm at somewhat of a disadvantage because my ability to create a stabilizing force is minimized because the effort and the load are farther away from each other. I'm reaching out to get there. So in seated, when the patient's facing away from you, when you're behind the patient, it's a little bit easier to work on side bending. So I can palpate broadly. So the idea of broad contact for multi-point discrimination, I can identify where I'm moving to as is needed. And then when I frame, I've controlled the patient's body. So I have body contact with my thorax. I have contact coming across one shoulder girdle. I have my forearm draped along the other with broad contact. So now if I wanted for a patient active approach, I can have him take your left ear towards your left shoulder and let go. Now I've got lots and lots of contact. It's quite safe. So the keys here, as with anything else, is the idea that contact is control and control is safety. The patient or the table makes stable. Less table means I need to make the patient more stable. So the patient's in the seated position, so I consider the negative space. The space between us is unstable. So I make sure I approximate to the patient. I also consider my wardrobe. If I'm wearing a shirt with a zipper, as I am here, or a shirt with buttons, I'm careful with that. I pay attention and I don't place the patient's head onto my thorax, onto my sternum, against something that's going to hurt them. So if I was wearing buttons, I would probably unbutton to the point where I no longer would do that. If the patient is facing towards me, it seems to be easier to spot, so visually spot and palpate rotation, whereas if the patient's facing away from me, it seems to be a little bit easier to work in the coronal plane and side bending because I just have better holds. It's just the nature of me matching up with my patient. So those are some considerations with respect to treating the cervical column in a seated position. And also what we consider, to just go back to the concepts of assessment, macro identifies micro. So whether it's active or passive, if I use just general side bending or general rotation with respect to the cervical column, I can identify the motion preference. The one thing that I will warn you against, especially in the seated position, is that we understand that an occlusion test for the vertebral arteries is extension, side bending, and rotation in the same direction. So we understand that that can occlude blood flow to the brain, to the head, and it can, if there is a problem with the vertebral artery, it'll usually cause temporary blindness or loss of sight in the opposite eye. So if I was testing the left vertebral artery, I would often see blindness in the right eye if there was an issue. Now, understanding that that can occlude blood flow, it's something that I would avoid. So what I would suggest to you is whether you're in supine or in seated treating the patient's cervical column, I would generally avoid extension And I would suggest to you it's probably more intelligent to primarily work in one plane. It's primarily ideal to work in either rotation, which is generally preferable because you don't put any shearing force through the vertebral artery. However, if you do need to work in side bending for some reason, you want to keep in a relative neutral or mild flexion because it tends to be protective of the vertebral artery. So we don't want to see this. That's not ideal. We understand that if it's considered an occlusion test, if it can cause challenges to blood flow through the vertebral artery, it's not an ideal thing. You do not know if your patient has any form of issues brewing with a possible stroke on the way, transient ischemic attacks. So we don't do something that we know for sure can block blood flow. We stay in a relative neutral. Now the reason I say it's ideal to work in rotation is because you have relatively vertical structures in the vertebral arteries as well as the internal carotids, and as you turn, you don't bend through those arteries, you don't put force through them in translational fashion, you don't shear across them. If you have to work in side bending for some reason because the neck isn't responding to rotation, then what you ideally do is keep the neck in relative neutral. You don't extend and you don't heavily flex. You just keep them very, very contained, and you can work in that fashion. So ideally, you want to work in rotation. If you have to work in the coronal plane, if you have to work in side bending, then you're very, very careful with it. It's not necessarily a problem, but combining more than one plane when working in the cervical column gets you closer to possible danger with the vertebral arteries, and you want to be careful with that.